Okay, hello everyone out there in Amy J land. We are back here with the Creating Victory podcast. Get over it, make it happen, create victory in every moment. Thank you for listening, subscribing, downloading, sharing, learning, creating victory with us. We appreciate you. And I say this every time I have a conversation, but I have some big news coming, and this guy, Bruce Taylor, is an extraordinary human being. We're recording this on November 18th. It is National Diabetes Awareness Month. He has been living with type 1 diabetes since 1977. I have been living with type 1 diabetes since 1973, so we're diabetes siblings. Bruce has been one of the leading patient advocates from day one. He's had a 46-year career in the healthcare industry, government affairs, policy and advocacy expert. He's worked with Dexcom, the glucose monitoring companies, published articles on changes and the challenges that we all go through, especially in underserved communities, getting supplies, getting things covered, the fight, as we were just saying before we logged on, the full-time job of getting what you need to stay alive with diabetes. And now, as we speak, the challenges of getting, diabetes technology coverage, which is only going to help people lead healthier lives and help the economy because everyone will be functioning. So, Bruce, thank you. I'm so excited to have you here, and thank you for all you do. And share a little bit about your diabetes history and how you got so entrenched in advocacy and policy and all that stuff.
Amy, thank you for the opportunity to be able to sort of share my story. I was diagnosed in 1977, and it was almost by accident.
Hmm.
It was during, I was an athlete and I was going through a physical, and they said I was spilling a 4+ sugar.
Ooh. What does
I was
that
20,
mean? That's when you're
well,
in
it was,
a cup, right?
yeah, that's what it was, a urine test.
Yeah.
So in 1977, that was even before metformin was
Yeah.
available.
There was nothing.
So it was, you need to follow up with your primary care. Well, I was a world-class power lifter.
Hmm.
So I went to see my primary care, and he says, yes, you probably have diabetes. You need to exercise more and eat a healthy diet. And
God.
I was so frustrated by that because, okay, so a healthy diet's what my mother fed me. So a Southern Kentucky diet. And I told him I couldn't exercise anymore because I was training 3 to 5 hours a day, 6 days a week.
Right.
I had nothing left in the tank. Well, as it progressed, I had type 2 because I was 22. But then all of a sudden, massive weight loss.
Yeah.
And I was working for a pharmaceutical company at the time, and I was calling on one of the physicians, and the guy looked at me and said, "You look horrible."
Oh.
So I explained things to him. We went out the back door of his office, went to another back door, knocked on it. Another physician looked at me, did a blood test. He looked at me and says, "Son, you have diabetes, type 1.
Hmm.
We need to get you on insulin." So it started out with glass barrel syringes,
Yeah.
pork insulin.
Yep. I remember.
It was a 24 gauge needle. And the pork insulin, because it wasn't concentrated at the time, it was a pretty hefty injection.
Yeah.
And you got one a day. So I experienced the misdiagnosis, and it was sort of angered me because
Yeah.
they really didn't look. So Amy, you and I have shared the of living through history, the advancement in diabetes care.
Oh, yeah. There was no
The,
meter. There was no human.
no meters. I remember the first meter I got, it took 7 or 8 minutes to get a result. And I thought, boy, this is an advancement. And then you come to CGM, you come to the more advanced insulins that are much more concentrated, the advancement with GLP-1s.
Yes.
They're all game changers.
Yeah.
And as I've worked closely throughout the diabetes community, if you look at the American Diabetes Association standards of care, patients should get that at a bare minimum.
Right.
And as we age in Medicare, it's an interesting statistic. Medicare beneficiaries with a diabetes diagnosis have a 60% annualized hospital encounter rate. The vast majority of those encounters are preventable.
Right. Hypoglycemia, the tech.
Hyperglycemia, the other challenge is that blood sugar, if your sugar is controlled, your cholesterol is lowered.
Right.
It reduces the burden on your heart. It reduces the burden on your kidneys. It reduces the burden on your brain.
Joints, on your
Yeah,
extremities,
it reduces,
inflammation, all of it.
yeah, retinopathy, neuropathy, the onset of dementia is all caused by high blood pressure spikes. These are all preventable conditions.
Yeah.
40% of dialysis today or more is uncontrolled
Diabetes.
blood glucose and
That
high blood
happened to
pressure.
me. That's why I lost my vision. I was young. I ate what I wanted. I was rebellious, like, cheesecake and
It's,
donuts, and out went the eyes. My
yep,
doctor literally said, "You're gonna kill yourself." My first A1C, which is a 3-month glucose test, was like 13
yep.
something. And I was like, "Oh, I'm managing." They said, "No, no, no, you're not." Like, no, you're not. So it was a real fork in the road for me at age 21. Like, do you want to live or you want to die? Because you've already lost the ability to drive. So the impacts, thank you for sharing that, are so profound. And we know about carbohydrate and inflammation and, the
Yep.
effects on the cells and the diet here in America, which is a whole other problem. The lack of exercise, the technology. So I'd love for you to speak a little bit about some of the policies that DPAC and you all have been trying to push through. I know you were recently in DC, and the work that you're doing on the ground that people might not see happening because they only see what the media feeds to them, to get coverage, to get care, to get preventative care, all of that. The formularies we were talking about, the freaking formularies, which isn't the word I would use if I wasn't on
Yes.
interview, but
The main areas that we've been working on is pharmacy benefit manager reform.
explain that to people because I didn't even
But
understand what that
so
means.
a pharmacy benefit manager is an intermediary between the payer, which could be your self-insured employer, it could be Medicaid, it could be Medicare, and the pharmacy. They contract with the pharmacy. The pharmacy benefit manager neither touches the product or the patient. They
Hmm.
just handle the billing transaction and it's all done electronically. But they negotiate with pharma manufacturers for rebates. So as patients with diabetes, 1 year you're on Humalog, the next year you're on Novolog, you're on Tresiba. No, they want you to go to Lantus.
I just went through
All
that. You're on Tresiba. It was $601.99. It will cover Lantus. I said Lantus. And if you're listening and you don't know what we're talking about, these are different types of insulins that have different long acting, short acting, and they're all necessary. Again, like you said, this isn't a one size fits all. So what works for me isn't going to work for you. But for the pharmacy to say, well, we're not going to cover X, but we'll cover Y. And I said, well, Y is going to put me in the hospital. So it's not the pharmacist's fault.
it's the PBM that sets up a
Yeah.
formulary. And a formulary is simple, a list of what they cover that drives their profitability. They're publicly owned companies.
Companies, yeah.
Their commitment is to the shareholder and not to the patient.
So how do we rectify this formula? I
And
mean,
this
I
is
have a
the
plan, but I can't share it yet.
and this is where the advocacy comes in and why we were recently on Capitol Hill talking to members of Congress and their staff about this reform and how it impacts people's lives. At the end of the day, the only two people that really count are the physician and the patient in the room.
Thank you. Thank
The
you. Thank you.
physician understands me. I understand my physician. And we talk about what my therapy is going to be because I have to execute that therapy. I have been an unlicensed practicing endocrinologist with one patient for 48 years
Me too.
because you're on your own. It's quote a self-managed condition.
Right.
And people have a real difficult time with understanding what it means by self-managed. So PBM reform that those rebates should be passed to the patient at the point of sale.
Agreed.
And that's what we advocate for in Washington.
And the PBMs are, the companies are currently big donors, aren't they, to both sides of
They it
Congress, all
it
sides
is
of
a yes,
Congress?
they have significant revenue. These are multi-billion dollar organizations.
Yeah. So they're
So
funding,
their influence on Capitol Hill, we're the lone voice of the patient,
right?
but members of Congress are listening to it to say, this is not right. Why should I, as a patient with diabetes, we were able to get legislation passed that there's a $35 per month cap on insulin for Medicare beneficiaries. Why isn't there a $35 cap for anybody and
Everybody.
everybody who's on insulin?
And that's if you're in their formulary, because I also have Medicare because of my disabilities. And they still, the Tresiba, they have now said I don't need because it,
And it changes every year because it depends on what rebate. It is a financially driven formulary. How do they make the best margin?
it's crazy.
The other piece that we were talking on Capitol Hill about is that the Centers for Medicaid and Medicaid Services, or CMS,
Mhm.
dropped a proposed rule for competitive bidding for continuous glucose monitors, or CGM, and insulin pumps.
Please explain that because I've been on some of those calls and it's absolutely horrifying.
So what they decided to do is that they said, okay, these are products used by a lot of people. Well, guess what? There's 38 million Americans that are part of Amy and I's diabetes family. These are the advancements and breakthroughs that are making lives normal. Standard of care when a child is diagnosed with diabetes and type 1, before they leave the hospital, they're hooked up to a continuous glucose monitor and an insulin pump. That's standard of care.
Yeah,
But they want to go out and they want to competitively bid it. Now, as a taxpayer, sure, I want the government to try to save money. But the rule that they dropped, they wanted the regulatory accountability and responsibility that lives with the manufacturer now to be shifted to the supplier or the DME mail order house. They're not
what
equipped
does
to
that
do
mean
that.
in layman's terms for people that don't really
They
have it
wanted
for
what they
policy?
wanted the suppliers to do was to service it. They wanted it so when Amy showed her receiver, she owns that receiver. What they want you to do is to rent that receiver. So if you wanted to change therapies, you could do that. But there's a lot of other ways to do that other than make it a rental.
Right.
So if your pump goes down and you send it to a supplier, what are you going to be doing? Because if you were on an automated insulin delivery system where the CGM and the pump communicate, you've got a big treatment care gap.
Right.
Whereas today, if your pump goes down, you contact your pump manufacturer, they send you a
They
replacement
overnight
pump.
it.
They overnight it so that there is no
No.
divisions,
Yeah.
there's no open gaps of care. And then they send you a prepaid postage to send the old pump back.
Yeah.
So you're never you're there's no gaps in therapy.
I did that when I was on a pump some years back, and it was pretty seamless.
So for the patient, there is a focus. The manufacturers understand what it's like. In my career, I worked for Roche Diabetes Care and I worked for Dexcom. I can't tell you the number of patients that are part of the diabetes family that live it every day. So when they put policies together to help patients, it's from personal knowledge
Yeah.
and understanding if you do it this way and it takes an extra 2 days, what does that mean to the patient and their family?
And
So
this is
it's
going on right
driven by
now.
passion.
Yeah. This is, I know this is, we were just on a call a few weeks ago about this whole technology situation. So, you know, again, it's how to put the people first, which
It
is
is in Congress, it's things are done with good intentions, but they don't understand the unintended consequences.
right.
They tried this competitive bidding program with diabetes test strips and meters. I was fortunate. I worked with a gentleman with the National Minority Quality Forum. We published a big study. We showed significant disruption
Right.
in patients. As soon as you stop testing or managing your diabetes, bad things happen and they happen quickly.
Which ends up costing, if they're talking about cost savings, it just common sense would say it doesn't make sense if you have to go to emergency, if you have to get an operation for $50,000, if you have to get IV glucagon, or if that's a
Yep.
shot that costs, I don't know what the cost of it is because I don't personally need it, but it ends up costing so much more than just, the $100 for the strips or the $500,000 for the kidney transplant. It seems so simple, yet like I don't
It's
know. Like I'm
it,
not
it's logical. Unfortunately, CMS views things as a line item. So we want to save money on this line item, not understanding how it impacts hospitalizations, emergency room visits. And we did a very detailed analytics that was published in Diabetes Care. So it was peer reviewed and vetted extremely well. What we saw is there was significant disruption with people testing fewer times.
right.
The
And what does
people that
that
tested
mean?
fewer times, hospitalization statistically significant rose, emergency rooms rose, and more importantly, mortality went up.
Of course it did,
So they're trying to save costs, but at what price?
right. And
And I think
the
there's
system,
no safeguards
yeah.
for the patient if you don't understand the condition of diabetes. And if you force a Medicare beneficiary to change, Amy, if we look up change in the dictionary about the third definition down, it says when you're 65, it's something you don't do. Because all
Exactly.
of a sudden I had to find a new supplier because they had 1,200 suppliers and they got it down to less than 10.
Right.
Well, that means I got to go to my physician. I have to have that, man or woman redocument
You do
all
everything.
my orders and all the documentation. Today, I've still got to see my endocrinologist every 6 months in order to be able to get
Me too.
my continuous glucose monitor. And you have to document all that.
More paperwork for everybody. Yeah.
And people are overall, I would say the American public is extremely smart in their chosen profession. When you start going into healthcare, even though I've worked in healthcare for damn near half a century, I still find nuances,
Right.
but I advocate for myself, for my family, for the diabetes community, because I know how to fight the system.
Speaking of which, and this is all, I can't wait till I can share my upcoming news because um, I'm specifically being cryptic about it. Um, so we've heard a lot recently to kind of segue about the subsidies again with the shutdown, which we discussed earlier that I can't share my views about here. And the payback to the insurance companies, what happens to the cost to the consumer. This is a huge, it's actually up for vote, I think Friday. Um,
Yeah.
can you explain a little bit in layman's terms because it's very complex and people, again, are only fed what the media feeds them and they're backed by big pharma. So,
The challenge that I see, the lack of the subsidies, will those subsidies offset the cost of the premiums?
right,
Risk pools, or the amount of people within a risk pool or that are insured, they balance. Think of it as a pyramid. You have people that consume a high amount of healthcare at the top of the pyramid. Then you have people that are paying the same premiums way down at the bottom, and it's a big population. That offsets the risk, so you have more affordable premiums for everybody.
right.
Without the subsidies, pre-existing, people could start discriminating because you have pre-existing conditions. Oh, you have diabetes, you have hypertension, you have a little bit of kidney problems. Oh, the cost to insure you's got to be that much more.
Right.
They've lost the understanding of how that risk pool is going to go.
Well,
So
wasn't
I
that
think
part of the initial ACA? And again, I'm not an expert on this, although I need to study it further in terms of the price for pre-existing.
conditions. So that's the challenge. What I find very interesting is the current Speaker of the House in his district has the highest percent of Medicaid recipients in a congressional district than anywhere in the country.
Isn't that ironic?
So you've got the premiums. How do we control the premiums? Because we're right now in the middle of open enrollment that ends December, the first week of December.
Yeah,
The next challenge is that then they said, okay, we're going to take X number of $800 billion out of Medicaid with this supposition that people that don't qualify for Medicaid, undocumented illegal aliens, are getting all these benefits. Well, guess what? That is a falsehood. That is fake news at its worst.
mm,
Because if you know anyone that has applied for Medicaid within their state, it's one of the hardest insurances to qualify because you have to document your
everything.
citizenship, your residency, everything else to qualify for Medicaid within your individual state.
I had to do it when I was younger, post-accident. Yeah, I had to get
So
help.
it's
Crazy.
so this thought of we're spending all this money on people we shouldn't be spending it on. However, the healthcare system in the United States, if you show up at the hospital, you are not denied care.
Right.
So if you are undocumented, illegal, or whatever, your care is not going to be
Discriminate.
denied when you go into the hospital. There is a part of that in order to keep a lot of hospitals open that states and the government can say you can use a portion of your funding to provide that care. There was a recent study that was released about 3 weeks ago that said less than 1% of the funding goes for that level of care. But the current administration has spun it and said, well, there's $1 billion being spent. Well, guess what? It is a multi-trillion dollar budget.
Right.
So 1% of something multi-trillion is close to $1 billion. So it is what it is. But
Right.
they've spun it in all different types of directions. For the diabetes community, Medicaid is moms and kids predominantly.
Yeah.
And states by statute have to have a balanced budget every 2 years.
Ha.
So it's not like they just can't call the mint in DC and say print more cash.
Yeah.
They can't do that. They have to balance the budget. There are so many levers to control costs with the state, they can only do the following. I can reduce the reimbursement of what I pay hospitals and physicians, which they're already doing.
It's crazy. The very people that are going to save people's lives.
Here's the challenge. Right now, if you're a physician, if you take, here's the number of patient visits I got, here's my total overhead, divide it, what is my cost to serve on average? A Medicaid reimbursement, they lose money seeing and treating that patient.
Yeah.
So
Most
if you
of my
reduce it,
doctors have dropped all of that, Medicare, Medicaid, because
yeah,
it's,
they're just saying, I can't afford to practice because it doesn't make good business sense
yeah.
because they have families and their own financial well-being that they have to look out for. So the population of physicians treating these patients is going to go down.
Dwindling.
So next thing they could do is that they could come back and restrict the benefit category. Make it more onerous for people to get technology or the new advancements in medications. Third, they could completely eliminate the benefit. Say that we're no longer going to cover it.
Mm.
So if you're on Medicaid, and they also, when they passed that law, it triggered pay-go rules that they have to, and nobody wants to say this, but it's going to trigger cuts for Medicare. They said we didn't touch
Has to,
Medicare.
but it has
Not directly, but through the pay-go rules, they had to come up with other
solution.
hundreds of billions of dollars over a 10-year span. Meanwhile, the tax breaks are still going to add to the national deficit.
So what do
So
we do? How can we move the needle? Change is hard and change is slow, and you're entrenched, and I will hopefully be entrenched.
I think part of it is the one thing I have learned, a single voice can make a difference. A single voice can make a difference. In my career, I've built coalitions.
Hmm.
So I build choirs. Once the choir starts singing, people pay attention.
Yeah.
There's a rule of sevens for members of Congress. If they hear the complaints at least 7 times from their constituents, their staff starts to alert the member, Houston, we have a problem.
Actually, I did not know that. That's good to know.
So the more we can have constituents, voting members of Congress, because the motivator for Congress is to be reelected. So the more we can communicate, illuminate, educate members of Congress and their staff, and using the following principles. Here is the problem with your coverage policy with diabetes. Here's how it negatively impacts me. And here's what I want you to consider doing about it. You have to have an ask
Yeah.
because they'll sit there very graciously and listen to you go in and agonize about your challenges. But then they leave and they're
There's
saying,
no solution. Yeah.
it's like, well, what do you want me to do about it?
You have to
What should I
still feed
fix?
them. Yeah.
Yeah, give me, they may not agree with your recommendation, but it gives them something to ponder and think about. And that's what we did when we were there in Congress.
Yeah. I've been on those Hill days. I went back in 2019 and then on Zoom during the pandemic. you know.
I've been in and out of offices over the past decades, hundreds of times. I always have an ask.
Yeah.
I want you to co-sponsor this legislation. I want you to become a member of the Diabetes Caucus. I want you to strongly request from CMS, how are you going to protect beneficiaries with this harebrained bidding process?
Yeah.
Can I come back and explain it to you?
Yeah.
Will you be our champion?
Yeah.
If they say no, that's just the next excuse to call them back.
Oh, I love that. Yeah. It's like never take
It
no. Just
you
keep.
you ne you never take no for an answer. It's like my grandchildren negotiating for the candy at the checkout in the grocery store. That they're like pesky little pests. At a certain point, in order to get them to be quiet, the little bag of peanut M&Ms is a small price to pay for silence.
That's a very practical analogy.
And it's the same way with Congress.
Ah.
I have fought for expanded coverage policy for CGM,
Oh my God.
and the staff of the leadership of the Diabetes Caucus, they said, "You're not going to go away, are you?" No, I can't, because this is really hurting the lives of patients.
Millions and millions of patients.
There's millions of us. You're just getting to hear my one voice.
What's the total numberage in America? It's crazy.
38
Yeah.
million and 38 million and growing. And the unfortunate part, if you're a member of a community of color, the disparities in your community
Oh yeah.
are the most unjust things on the planet in the world's richest nation.
The food desert, the yeah.
Food deserts, the ability to get standards of care, um, visual discrimination,
Yes.
people making judgments. Well, I don't know if this person can handle this technology or not. You never ask them.
Right.
I was blessed to meet Sam Walton,
Really?
and Sam was a very unique character because if you met Sam, he might be a patient. You say, I don't know if he'd do technology because he drove an old pickup truck that burned oil. The back of his truck had empty oil cans and a case of oil because he always had to stop and check.
Oh my gosh.
But he was the humblest man I've ever met.
Hmm.
But let me tell you something, the man was incredibly smart.
Well, obviously, yeah.
So when people judge the book, the book by the cover, and I think that's exactly what happens when a physician gets in the treatment room. One, they make a judgment. Two, they have to see a patient every 10 minutes.
I was gonna say they don't have time to find out what's
They don't have
going
time to
on.
find out
Yeah.
because it's going to take time because, hey, they may ask a question that
I
and
don't
then you have electronic healthcare records that um, are just burning physicians out.
yeah. They're burning the patients out. I mean, it's crazy. You can't get a human on the phone anymore. Even I need
You
X, I need
can't,
Y, call this one, do this one, go on the app. I said I can't go on the app. I have a visual disability. I need someone I don't do on the phone. It doesn't work for me. Like,
yes. I want to talk to a human being, not an AI bot.
right. That's a whole other separate episode.
Yeah. But that's the process that we're going through.
Yeah.
We have the Diabetes Patient Advocacy Coalition, the Diabetes Leadership Council. We have Beyond Type 1, Diabetes Sisters, Children with Diabetes. These are all organizations that work to ensure that patients and their families
Get what they
get,
need.
get standards of care and get what they need
Get
based on
support.
the interaction between the patient and the physician
Right.
with no interference with anybody else.
Absolutely. So what this is just so fascinating to me, and I could be here all day with you, but I mean basically what you're sharing is power to the people? What can you share with our audience who are thinking like I'm powerless or I can't afford it or I just don't have time? Average everyday people struggling to just put food on the table. Like, what can we do to move the needle? Because change is
There,
slow.
there are advocates, there are advocacy, like the Diabetes Patient Advocacy Coalition, the Diabetes Leadership Council, um, Beyond Type 1. Google them,
Yeah.
sign up,
Get on their websites. Yeah.
get on their website. So if there is an issue,
You'll know.
you'll know they have such advanced technology is that here's the issue, here's our position to fight it. Remember the rule of seven?
Mm-hmm.
You put in your name, your address, and your zip code, it automatically identifies your congressional delegation. And when you hit send, you just need six more.
Let's get to work.
It doesn't take a lot of time to share your voice
Yeah.
because that is the most important thing that we in the diabetes community have is our voice.
Absolutely. This is what I'm all about, and hopefully on a much bigger scale to just power back to the people that there's a lot we can do. So don't be swayed. Bruce, you are an absolute wealth of experience, information, breaking things down so that us normal people can understand them. Sometimes I think they make it so complicated that we're just like, oh, I can't figure this out. So thank you. Thank you to our audience. Please reach out, go to these resources, ask questions, and don't stop until you feel like they're answered. Trust your instincts, share, download, and thank you, and create victory in every moment.